Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is August 17, 2025. This video is on a Nature Reviews Cardiology article published this year titled Salt Sensitivity of Blood Pressure, Mechanisms and Sex-Specific Differences. What is salt sensitivity of blood pressure? Salt sensitivity of blood pressure is the degree to which the individual's blood pressure rises or falls in responses to changes in dietary salt intake, independent of hypertension status. How common is salt sensitivity of blood pressure? It occurs in 25% of normotensive individuals and about 50% of those with essential hypertension. Why is salt sensitivity of blood pressure important? It's an independent risk factor for cardiovascular disease and mortality, even without established hypertension. How is salt sensitivity of blood pressure diagnosed? Currently through salt loading and depletion protocols, which are accurate but impractical in routine clinical care. Are there population differences? Yes. Prevalence and severity vary by gender, ethnicity, menopausal status, and comorbid conditions such as autoimmune diseases. Mechanisms and sex-specific differences. Why is salt sensitivity of blood pressure more common in women? Women both pre- and postmenopausal exhibit greater salt sensitivity of blood pressure than men, possibly due to difference in sex hormones, renal transporters, and immune responses. How do estrogens influence salt sensitivity of blood pressure? Estrogens promote specific nitric oxide production, enhance vasodilatation, and dampen the RAAS activation, generally protecting premenopausal women. Loss of estrogen after menopause increases the risk of salt sensitivity to blood pressure. What's the role of testosterone? Testosterone raises blood pressure by activating RAAS, blunting baroreflex sensitivity, reducing natriuresis, contributing to salt sensitivity of blood pressure in men. What about the RAAS pathway? RAAS dysregulation is central. Men show stronger Ang2 AT1 receptor vasoconstriction, whereas women have more aldosterone-driven sodium retention, especially post-menopause. Are there immune system differences? Yes. Male immune responses in salt-sensitive blood pressure are more pro-inflammatory, Th17-driven, whereas female rely on T-regulatory responses, partially protecting against hypertension. Limitations of and lessons from experimental models. Why are animal models used? Rodent model example the Dahl sensitive rat allow mechanistic study of hormones, the RAAS pathway, the sodium channel, and immune responses in salt sensitivity to blood pressure. What are the limitations of these models? Findings can vary depending on diet composition, strain, and hormonal manipulations, leading to inconsistent results. Do rodent findings always translate to humans? Not always. For example, ovariectomy effects differ across studies, showing the complexity of sex hormone-dependent mechanisms. What have we learned from the models? That sodium channel activity, aldosterone mineralocorticoid receptor signaling, and immune renal crosstalk are key regulators of salt sensitivity of blood pressure. Are autoimmune models informative? Yes. Rodent studies link high salt studies with worse outcomes in lupus-like and arthritis-like disease, paralleling human observations. Implications for therapy. Can salt restriction help everyone? Yes, but the magnitude of blood pressure lowering is greater in salt-sensitive individuals. Are there sex-specific therapies? Estrogen replacement in postmenopausal women have been shown to reduce salt sensitivity of blood pressure, though the benefit risks must be weighed. What about RAAS blockade? ACE inhibitors, ARBs, mineralocorticoid receptor antagonists may be especially effective in salt sensitive blood pressure, though gender-specific responses differ. Are sodium channel blockers like amyloid useful? They reduce salt sensitivity in blood pressure in some populations, but the response varies by race and gender, with weaker effects observed in black women. Does weight and fat distribution matter? Yes. Visceral fat increases the risk of salt sensitivity to blood pressure, more common in men, but rises sharply in postmenopausal women. Knowledge gaps and future perspectives. What are the main unknowns? Exact mechanisms linking sex hormones to sodium channel RAAS activity, the role of immune endothelial crosstalk, the influence of genetics and epigenetics on salt sensitivity of blood pressure. Why is menopause a turning point? Because estrogen loss shifts women towards higher aldosterone-driven RAAS activity and vascular dysfunction, making them more salt sensitive. Are better diagnostic tools needed? Yes, as current salt loading protocols are impractical for clinical use. Biomarkers and genetic predictors are under investigation. Is personalized therapy possible? Future strategies may involve tailoring RAAS blockade, hormone therapy, or dietary based on gender, menopausal status, and genetic profile. How does this research affect public health? It underscores the need for sex-specific hypertension guidelines and stronger dietary sodium reduction strategies. Key takeaways: salt-sensitive blood pressure is an independent cardiovascular risk factor present in 25% of normotensives and 50% of hypertensives. Sex hormones: estrogen is protective, testosterone is oppressor. Sex hormones play critical roles. Women have greater salt sensitivity blood pressure than men, amplified postmenopause. RAAS pathway, sodium channel activity, and immune pathways are central drivers. Personalized sex-specific prevention and therapeutic strategies are needed. This is an infographic on the key drivers of salt sensitivity. So it's the epithelial sodium channel, the RAAS pathway, the immune system, and sex hormones. Eponyms in salt sensitivity and hypertension. The Dahl sensitive rat was developed by Dr. Lewis Dahl, cornerstone experimental model for genetics salt sensitive hypertension. The Little syndrome, described by Dr. Grant Little. Epithelial sodium channel gain of function mutations cause early severe hypertension. Conn syndrome by Dr. Jerome Conn. Primary aldosteronism, excess aldosterone driving sodium retention and salt sensitivity to blood pressure. The Guyton's pressure natriuresis model, Arthur C. Guyton. Kidneys failure to excrete sodium long-term leads to hypertension. Gordon syndrome, Dr. Richard Gordon. Pseudo-hypoaldosteronism type 2. Hypertension from enhanced distal sodium chloride reabsorption. The Kirabo pathway, Dr. Annette Kirabo. Epithelial sodium channel mediated sodium entry in immune cells eventually results in inflammation and hypertension. The GenSalt study, that's the Genetic Epidemiology Network of Salt Sensitivity, multi-center trial confirming genetic and ethnic contributions. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.